Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 248 of our pharmacotherapy series, which majors in infectious diarrhea. The first question reads, WSD and BUD are healthy 23-year-old females beginning a 2-week backpacking trip through Latin America. Prior to their departure, both travelers attended a travel clinic where they received instructions to minimize their risk for travelers' diarrhea, and a travel kit including instructions and medications for the self-treatment of travelers' diarrhea. On the day of their arrival, both travelers seek out local street vendors, sampling their fresh fruits, vegetables, prepared foods, and unbottled beverages. On the second day of their vacation, both travelers are not feeling well. WSD notes only the passing of 2 to 3 watery stools without blood, and mild nausea. In contrast, BUD is feeling much worse, noting the passing of 6 to 7 loose, bloody stools, abdominal cramps, and feeling feverish. Neither traveler feels dizzy or thirsty, and both are able to continue drinking unbottled water and juices. What are their risk factors for travelers' diarrhea, and why are their clinical presentations consistent with this diagnosis? Let's begin with the risk factors. Both travelers have several risk factors for acquiring travelers' diarrhea. First, their travel to Latin America, a destination considered high risk for travelers' diarrhea, i.e., equal to or more than 20% risk within the first 2 weeks of travel. Other high-risk destinations include South Asia and West or Central Africa. Second, because the highest risk for travelers' diarrhea is during the first 2 weeks of travel, their recent arrival to an at-risk destination increases the likelihood for infection. The risk for travelers' diarrhea lessens during the second week of travel, that is 9.9% risk, and third week of travel, that is 3.3% risk. Third is their travel style of eating foods with a high risk for contamination with enteropathogens such as foods from local street vendors and drinking unbottled beverages. Additional high-risk foods include ice cubes, raw milk, unpeeled fruits and vegetables, uncooked foods, moist foods, foods remaining at room temperature for prolonged periods of time, allowing bacteria to multiply or release their enterotoxins, use of acid-inhibiting medications allowing acid-susceptible enteropathogens to pass through to the intestines, and genetic predisposition. Regarding the clinical presentation, travelers' diarrhea is defined as 3 or more loose, unformed stools per day plus at least one symptom of enteric infection such as abdominal cramps, nausea, vomiting, fever, fecal urgency, tenesmus, or the passage of bloody or mucoid stools. Like in these travelers, illness typically begins within 24 to 48 hours after consuming fecally contaminated foods. Left untreated, travelers' diarrhea is generally a self-limiting illness lasting 4 to 5 days. The next question reads, what general approach should WSD and BUD take to manage the diarrheal illnesses? Realizing that their symptoms are consistent with travelers' diarrhea, both travelers review their pre-travel information for the self-management of travelers' diarrhea. Regarding hydration, to replace fluid and electrolyte losses they should continue to drink only bottled or boiled liquids such as tea, broth, carbonated beverages, and fruit juices. Electrolytes can be replaced by eating salted crackers or similar sources of sodium chloride. For travelers able to drink fluids ad libitum, a modified World Health Organization oral rehydration solution offers no additional benefit over the administration of loperamide alone. Neither traveler has symptoms indicative of significant dehydration such as thirst, dizziness, or altered mental status. Let's now look at the principal safe foods: peel it, boil it, or forget it. Travelers should avoid consuming foods with a high risk for contamination with enteropathogens such as raw vegetables, fruit they have not peeled themselves, cooked food not served steaming hot, and tap water. Instead, they should only eat fruits that they have peeled themselves or that have been adequately washed, and well-cooked foods served steaming hot. Enteropathogens are killed at 100 degrees Celsius and foods served piping hot at 60 degrees Celsius are generally safe. Despite adherence to dietary restrictions and precautions, prevention of travelers' diarrhea is not always possible, likely reflecting the difficulty with adhering to sanitary standards for the preparation and serving of foods, the lack of facilities for employees to wash their hands after going to the bathroom, or the lack of screens or windows to prevent flies from contaminating foods. We will now comment on self-treatment of travelers' diarrhea. Antimotility agents alone provide rapid relief of symptoms but do not cure the infection, whereas antimicrobials alone will cure the infection but symptoms may persist for a longer time. In the appropriate setting, antimotility drugs plus antibiotics provide the fastest relief of diarrheal symptoms. Selection of a self-treatment plan is, in part, based on the traveler's severity of illness and manifestations of the diarrheal illness. The next question reads, for travelers with the following manifestations of traveler's diarrhea. A. Watery diarrhea without blood or fever, or B. Bloody diarrhea or fever, or C. Diarrhea while taking chemoprophylaxis. What are the common microbial etiologies, and what treatment options are available to manage these diarrheal syndromes? The microbial etiology of travelers' diarrhea is recognized in 50% to 94% of patients with bacteria most commonly identified. Viruses and parasites are less frequently isolated. For travelers to developing countries, the most common enteropathogen is enterotoxigenic Escherichia coli, abbreviated as ETEC, followed by enteroaggregative Escherichia coli, abbreviated as EAEC, diffusely adherent Escherichia coli, noroviruses, rotaviruses, Salmonella species, Campylobacter jejuni, and Shigella species. The likely enteropathogen afflicting individual travelers can in part be predicted by the clinical manifestations of the diarrheal illness and the travel destination information, which is helpful for selecting an appropriate self-treatment plan. Let's briefly look at watery diarrhea without fever or bloody diarrhea. ETEC is suspected in the setting of acute watery diarrhea, especially in travelers to Latin America and the Caribbean, accounting for equal to or more than 35% of reported pathogens, Africa accounting for 25% to 35% of reported pathogens, and South Asia accounting for 15% to 25% of reported pathogens. ETEC produce enterotoxins that stimulate the intestinal mucosa to secrete fluid into the gut lumen, leading to diarrheal stools. We will briefly look at loperamide, diphenoxylate, atropine, bismuth preparations. Loperamide alone can be considered in patients with a mild diarrheal illness, e.g., 2 loose stools and mild symptoms without fever or bloody stools. Loperamide rapidly relieves diarrheal symptoms, often within less than 24 hours, and is better tolerated than diphenoxylate, atropine. Mild diarrheal illness may be less likely to be infectious in etiology, but instead because of non-infectious causes such as anxiety, diet changes, and stress. Bismuth subsalicylate is moderately effective in improving diarrheal symptoms. Alternatively, travelers on a short and critical trip, e.g., business, might consider the addition of an antibiotic. However, the potential adverse consequences of antimicrobial therapy, such as the risk for adverse drug events, additional cost, and antimicrobial resistance, should also be considered. A recent prospective study reported that depending on the travel destination, the risk for a traveler with diarrhea becoming colonized with extended-spectrum beta-lactamase producing Enterobacteriaceae was greatest, 28% to 80%, if an antimicrobial was taken versus if no antibiotic was taken, 8% to 47%. After returning home, up to 24% of travelers remain colonized at 6 months and 10% remain colonized at 3 years. Consequently, some experts do not recommend antimicrobials for mild to moderate disease nor for the prevention of travelers' diarrhea. I will briefly comment about antimicrobials alone. Rifaximin, ciprofloxacin or levofloxacin, or azithromycin are recommended for travelers with watery diarrhea without fever or dysentery. For travelers to Mexico or Kenya where ETEC is a frequent cause of travelers' diarrhea, a single dose of ciprofloxacin 500 mg, azithromycin 1 gram, or levofloxacin 500 mg decreased the median time to passage of the last unformed stool to 22 to 33 hours versus 54 to 66 hours for travelers given placebo. For travelers to Mexico or India, oral rifaximin 200 mg 3 times daily or ciprofloxacin 500 mg twice daily for 3 days significantly reduced the median time to passage of the last unformed stool to 32 hours and 29 hours, respectively, versus 66 hours for travelers taking placebo. Rifaximin is not systemically absorbed, is well tolerated and has a low potential for the development of antibiotic resistance. Regarding antimotility drugs plus antimicrobials, the combination of antimotility drugs plus antimicrobials provide the fastest relief of diarrheal symptoms. The antimotility drug quickly acts to reduce the number of stools, whereas the antimicrobial cures the infection. In military personnel stationed in Turkey with travelers' diarrhea primarily caused by ETEC, the median time to the passage of the last unformed stool was shortened to as little as 3 hours in recruits taking oral loperamide, dosed at 4 mg initially, then 2 mg as needed. The maximum dose is 16 mg per day, plus either levofloxacin single 500 mg dose or azithromycin single 1 gram dose. In otherwise healthy U.S. students at least 18 years old attending school in Mexico, the combination of rifaximin, dosed at 200 mg orally 3 times daily for 3 days, plus loperamide, dosed at 4 mg initially, then 2 mg after each unformed stool, relieved diarrheal symptoms faster, that is 27 ± 4.13 hours, than rifaximin alone, corresponding to 32.5 ± 4.14 hours, or loperamide alone, corresponding to 69 ± 4.11 hours. Next we will look at bloody diarrhea with or without fever, or diarrhea while taking chemoprophylaxis. Invasive pathogens including Shigella, Campylobacter, and less commonly Salmonella, non-cholera Vibrios and Aeromonas species are suspected in the setting of acute bloody diarrhea with fever. Campylobacter species are frequent causes of travelers' diarrhea in travelers to Southeast Asia, 25% to 35% of reported pathogens, and South Asia, 15% to 25% of reported pathogens. Antimicrobials alone. A comparative study reported the highest cure rate with a single dose of azithromycin 1 gram, 96%, followed by 3 days of either azithromycin 500 mg daily, 85%, or levofloxacin 500 mg daily, 71%. The lower cure rate with levofloxacin was because of infection with levofloxacin-resistant Campylobacter species. Nausea during the 30 minutes after receipt of the first antimicrobial dose was more common in persons given 1 gram of azithromycin versus the other regimens, 14% versus less than 6%, respectively. Rifaximin should not be used in patients with diarrhea complicated by fever and bloody stools, being ineffective against invasive enteropathogens, e.g., Salmonella, Shigella, and Campylobacter species. The next question reads, based on the symptoms each traveler is experiencing, what drug therapies are available for WSD and BUD that can be considered to reduce the duration and severity of their traveler's diarrhea? For travelers with mild watery diarrhea without fever or bloody stools, like WSD, loperamide can be used, often relieving symptoms in less than 24 hours. If improvement is not evident within 12 hours, an antimicrobial could be started. For travelers with moderate to severe diarrhea with fever or bloody stools, like BUD, antimicrobial therapy is recommended to shorten the duration and severity of the diarrheal illness. Treatment options include a fluoroquinolone or azithromycin. Azithromycin is recommended for travelers to areas with a high prevalence of fluoroquinolone-resistant Campylobacter species, including Thailand 93%, Nepal 71%, Asia 70%, Latin America 61%, and Africa 31%, or for travelers not responding within 48 hours to a fluoroquinolone. Rifaximin is not effective for travelers' diarrhea caused by invasive enteropathogens and not recommended for BUD. The next question reads, 3 weeks after returning from their trip, unlike WSD, who is free of intestinal symptoms, BUD continues to have episodes of loose stools and abdominal discomfort, for which she seeks medical attention. On physical examination, her vital signs are stable and she is afebrile. The physician believes her symptoms are consistent with post-infectious irritable bowel syndrome, abbreviated as PIIBS. What are BUD's risk factors for PIIBS and why is her clinical presentation consistent with this diagnosis? What therapies can be recommended to manage her symptoms? Let's consider clinical presentation and risk factors. Post-infectious complications of travelers' diarrhea include reactive arthritis and Guillain-Barré syndrome, which are associated with Campylobacter jejuni infection, and post-infectious irritable bowel syndrome, which may occur in 3% to 17% of travelers following a diarrheal episode by invasive pathogens including Campylobacter, Salmonella, and Shigella species. Risk factors for post-infectious irritable bowel syndrome include a severe episode of traveler's diarrhea, like BUD, the number of episodes, pre-travel diarrhea, pre-travel adverse life events, and infection with heat labile toxin-producing ETEC. Management treatment of post-infectious irritable bowel syndrome is aimed at providing symptomatic relief. Antimicrobials have not been proven to be beneficial and may be harmful. Diarrheal symptoms can be managed with loperamide. If postprandial fecal urgency is problematic, taking loperamide 30 minutes before meals is recommended. Bloating and abdominal discomfort can be managed with simethicone or antispasmodic agents. Chronic abdominal symptoms can be managed with low doses of amitriptyline and selective serotonin reuptake inhibitors. About 50% of patients with post-infectious irritable bowel syndrome recover within 6 years, although recovery is less likely in the setting of persistent depression or anxiety. Prevention of post-infectious irritable bowel syndrome with chemoprophylaxis of traveler's diarrhea has not been proven. A recent randomized, double-blind, placebo-controlled study evaluating prophylactic rifaximin for the prevention of diarrhea in travelers to South and Southeast Asia did not find rifaximin to reduce the occurrence of new-onset IBS. The absence of a benefit could be attributed to inadequate power of the study to detect a true difference. More studies are needed to address this issue. The next question reads, on hearing of the travels of WSD and BUD, friends JUG and TOM begin planning a similar vacation to Central America, but they want to prevent the occurrence of any diarrheal illness. Neither friend has any significant medical history. Should prophylaxis be recommended for these travelers? What drug therapies can be recommended for the chemoprophylaxis of travelers' diarrhea? I would like to briefly comment about candidates for antimicrobial prophylaxis and specific agents. Antimicrobial prophylaxis for travelers' diarrhea is recommended when the benefit of prophylaxis outweighs the risks of drug therapy, including adverse drug reactions such as photosensitivity with fluoroquinolones, bacterial resistance, and expense. In otherwise healthy persons, travelers' diarrhea is typically a self-limiting illness lasting several days, and should it occur, travelers' self-management of travelers' diarrhea reduces the time to the last unformed stool to within 24 hours of the onset of illness. For these reasons, routine chemoprophylaxis for travelers' diarrhea is not recommended. Chemoprophylaxis could be considered for travelers at greatest risk for infection or its complications, including persons in whom a short-term illness could ruin the purpose of the trip, e.g., athletes, politicians, lecturers, others, persons in whom a diarrheal illness could complicate an underlying medical problem, e.g., insulin-dependent diabetes mellitus, congestive heart failure, reactive arthritis, inflammatory bowel disease, advanced cancer, or HIV infection, and persons with conditions which increase the risk for enteric infection, e.g., genetic predisposition, gastric disease or surgery, or use of acid-reducing medications. If offered, chemoprophylaxis should not extend beyond 2 to 3 weeks. Thus, these travelers are not candidates to receive antimicrobial prophylaxis for travelers' diarrhea. Instead, at the onset of illness, they should follow their self-treatment plan for travelers' diarrhea they received from the pre-travel clinic visit. For travelers who are candidates for chemoprophylaxis of travelers' diarrhea, the following options are available. Regarding antimicrobials, chemoprophylaxis with a fluoroquinolone, ciprofloxacin 500 mg or levofloxacin 500 mg given daily during travel but not exceeding 2 to 3 weeks and for 2 days after return, is recommended to reduce the incidence of diarrheal illness. However, the current efficacy of fluoroquinolones should be viewed with caution, given rising fluoroquinolone resistance in common enteropathogens including ETE, C and EAE, C in India, and Campylobacter species in Asia and Latin America. Azithromycin 250 mg daily is an alternative chemoprophylactic agent and preferred for travel to destinations where Campylobacter species is a common cause of travelers' diarrhea, e.g., South and Southeast Asia. Rifaximin is not FDA approved for the prophylaxis of travelers' diarrhea, but it has been effective for the prevention of travelers' diarrhea in students traveling from the United States to Mexico where ETE-C is a common enteropathogen. A more recent randomized, double-blind, placebo-controlled study showed only a modest 48% protection benefit of rifaximin compared to placebo in otherwise healthy travelers to South and Southeast Asia, areas where enteroinvasive pathogens are frequent causes of travelers' diarrhea. Regarding the miscellaneous agents bismuth subsalicylate, 2 tablets, that is 526 mg, dose, 4 times daily for a maximum of 3 weeks has a protective efficacy of 65% against traveler's diarrhea. The problems with BSS because of inconvenient dosing, salicylate content, and unpleasant adverse effects as mentioned before need to be considered. Probiotics have been studied on the basis of their ability to prevent enteropathogen colonization. The effectiveness of probiotics has not been determined and more studies are needed before these agents can be routinely recommended. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 249.